Hello everyone, this is Dr.Manikanta MD, currently doing DM Gastroenterology in AIIMS. Today we are going to discuss regarding the heart blocks in 10 minutes. Let's begin the session. When we call it as bradycardia, when the heart rate is less than that of 60 beats per minute, we call it as bradycardia, correct? The causes of bradycardia could be either sinus bradycardia or it could be due to heart blocks. So one reason it could be due to sinus bradycardia. The other reason is it usually could be due to heart blocks as well. So what is heart blocks? Block in the conduction system of the heart is called as heart block. So what is the conduction system of the heart? So we have the SA node, right? Then we have the AV node. From AV node we have the bundle of his. Then you have the right bundle branch. Then you have the left bundle branch. The left bundle branch has two fascicles, the anterior fascicle and the posterior fascicle, right? Supplying the ventricular myocardium via Purkinje fibers. These are the Purkinje fibers. Okay. So we have the SA node here. The SA node acts as a pacemaker of the heart due to overdrive suppression phenomena. That's a dominant pacemaker of the heart, right? The impulse from SA node reaches AV node via internodal fibers. How many internodal fibers we have? 3. We have the anterior internodal fiber, middle internodal fiber, and we have the posterior internodal fiber. This is AV node, correct? Above this is atria, below this is ventricle. Okay, here we have the bundle of his, here we have the right bundle branch, here we have the left bundle branch, here we have the left anterior fascicle, this is left posterior fascicles. These are Purkinje fibers. Okay, so what is heart blocks? Block in the conduction system of the heart, which can occur at the level of, so any of this part can be involved, that is any of this conduction system of the heart can be involved. That means it can occur at the level of SA node, which is known as SA nodal block. It can occur at the level of AV node, which is called AV nodal block. At the level of bundle of his, known as bundle of his block. At the level of left bundle branch block. This is known as right bundle branch block. Here we have fascicular block, that is left anterior fascicular block, left posterior fascicular block. So out of which is the most common type of heart blocks? Remember, AV nodal blocks are the most common type of heart blocks. These are the most common type of heart blocks. Okay, right. What is a bifascicular block? What is bifascicular block? And what is trifascicular block? And what is masquerading bundle branch block? And what is masquerading bundle branch block? Masquerading bundle branch block. Okay. Bifascicular block means right bundle branch block plus fascicular block plus a fascicular block. This is called as bifascicular block. Fascicular block means either left anterior fascicular block or left posterior fascicular block. Okay. What is trifascicular block? It is not called bifascicular block plus AV nodal block. Okay, this is known as trifascicular block. Okay, bifascicular block means right bundle branch block plus fascicular, which could be either anterior fascicular block or posterior fascicular block. And what is masquerading bundle branch block? It is RBB, that is right bundle branch block plus left bundle branch block. This is known as masquerading bundle branch block. Okay, out of which is the most common type of heart block? I already told AV nodal blocks are the most common type of heart blocks. So if not specified, heart blocks generally means AV nodal blocks. Okay. So what are the different types of AV nodal blocks? You know, if we talk regarding the AV nodal blocks, right? AV nodal heart blocks, which are the most common type. There are actually 3 types, right? We have first degree AV nodal block, then we have second degree, then we have third degree AV nodal block. So we have the first degree AV nodal block, then we have the second degree, and we have the third degree AV nodal block. Okay, just understand the concept first, then I will discuss regarding the approach as well. So what is the first degree AV nodal block? Where is the actual problem? Remember, come here. We know that ECGs, we have the P wave, then we have the PR segment, then the QRS complex, and the T wave, right? This P wave suggests of atrial depolarization, right? Atrial depolarization. The QRS is suggestive of ventricular depolarization. This T wave is suggestive of ventricular repolarization, correct? Then what is this PR segment suggestive of? AV nodal delay. AV nodal delay. Normally we have AV nodal delay of 0.1 seconds. This is normal AV nodal delay. Why there is AV nodal delay? To prevent a simultaneous contraction of atria and ventricles. Because of this delay only, there is a sequential contraction of the atria and ventricles, correct? Or this AV nodal delay in ECG is represented by PR segment. Okay, it is represented by the PR segment. SA nodal depolarization is by P wave. Then we have impulse reaches through internodal fibers, AV node. There is a delay for 0.1 seconds that is represented by PR segment. Then it passes into the bundle office, into the bundle branches, into the Purkinje fibers, into the ventricular myocardium. There will be depolarization leading to QRS complexes. Okay, then after depolarization there is a ventricular repolarization which is represented by the T wave, right? So AV nodal blocks means problem at the level of AV node, which could be first degree, second degree, third degree. What is the first degree AV nodal block? First degree AV nodal block is problem at the level of AV node. Okay, where is the problem? Pathology is at the level of AV node. And what is a pathology? It is a delayed conduction. Ante more than that of normal. Normally there is delay, but here there is exaggerated delayed conduction of the AV node. So this is only delayed conduction. Delayed conduction. There will be no failure of conduction. That means all the impulses which are reaching the AV node are conducted into the ventricular myocardium. There is no failure of conduction. There is no failure of conduction. There is no failure of conduction. Correct. So if there is a delayed AV conduction, so what will be the ECG finding? I told in ECG the AV nodal delay is represented by the PR segment. So what will happen here? There will be prolonged PR interval because of this delay AV conduction. Prolonged PR interval. When we call it as prolonged PR interval, the interval is more than that of 0.2 seconds. That is more than that of 5 small boxes. What is a normal PR interval? Between 0.12 to 0.20. If it is less than that of 0.12, we call it as short PR interval. If it is more than 0.20, we call it as prolonged PR interval. That is usually suggestive of AV nodal blocks. Okay, that is heart block. Okay, there is no failure of conduction. That means all the impulses. Remember here there is only delayed. Here there is only delayed AV conduction, but all the impulses from the SA node will ultimately be reaching into the ventricular myocardium. There is no failure of conduction. Okay, that's why all the impulses are conducted to the ventricle. That means every P wave is followed by the QRS complexes. That means there is no dropping of beats. There is no dropping of beats. Okay, this is for the first degree AV nodal block. Okay, now come to the third degree AV nodal block. Okay, the third degree AV nodal block means there is a complete failure of conduction. That means complete block. It is also called as complete heart block. There is complete failure of conduction. Failure of conduction. There is a complete failure of conduction at AV node, right? Suppose this is SA node, this is AV node, this is bundle office, bundle branch, right bundle branch, left bundle branch, this is ventricular myocardium, these are internodal fibers. Correct? If there is a complete failure of conduction at the level of AV node, so does the SA nodal impulse can reach into the ventricular myocardium? No. Then how the ventricles will now contract? Bundle office start acting as a pacemaker for the ventricle. Now this bundle office, SA node acts as a pacemaker for the atria. Bundle office starts acting as pacemaker for the ventricle. Remember, in our heart, the God has provided a multiple pacemaker. Every part of our heart can act as pacemaker, but the dominant pacemaker is SA node because of overdrive suppression phenomenon. Because of this AV nodal block, the overdrive suppression phenomenon is gone. The bundle office now start acting as a pacemaker for the ventricle. But what is the problem? The firing capacity of the bundle office is only 20 to 40 per minute. That means the maximum ventricular rate is only 40 beats per minute. Correct? Suppose this is enough. It can contract and it can supply the blood supply at rest. But on exertion, what will happen? Our body demands more blood. But because the bundle of his firing capacity is only maximum is 40 beats per minute, it cannot increase the heart rate. So what will happen? There will be reduced cardiac output. There will be reduced cerebral blood flow. This will lead to what? Syncopal attack. Right? This is known as Stokes-Adams attack. This is classically called as Stokes-Adams attack. Classically seen on exertion. Reduced cardiac output means the patient will not only have syncopal attacks but also reduced coronary blood flow as well. Therefore, the patient can also have chest pain. Okay, this is a problem with the complete heart block. So, what is acting as a pacemaker for the atria? SA node. What is acting as a pacemaker for the ventricles? Bundle of his. Therefore, there is a classically AV dissociation. AV dissociation. That means the PP interval is constant, RR interval is constant, but there is no relation between the P and the QRS. That is called as AV dissociation. Moreover, the SA node firing capacity of SA node is between 80 to 100, right? Therefore, atrial rate is more when compared to the ventricular rate. Atrial rate is in the range between 80 to 100 beats per minute. Ventricular rate is in the range between 20 to 40 beats per minute. How to calculate the atrial rate? Simple, 300 divided by number of large boxes between the PP interval. Here we have to take the PP interval. For ventricular rate, it is 300 divided by number of large boxes between the RR interval. Okay. What is the JVP sign of AV dissociation? Atria is contracting against a closed tricuspid valve, right? That is called AV dissociation. No? So there will be canon A wave. There will be canon A wave. One mid-diastolic murmur is heard in. One MDM is heard in case of complete heart block. What is the name of that murmur? It is called as right hand murmur. It is known as right hand murmur. Okay, this is known as right hand murmur. And what is a Dox murmur, by the way? Dox is also an MDM murmur that is heard in large stenosis, left anterior descending artery stenosis. What are the other MDMs you know? Mid-diastolic murmurs that you know? Austin Flint murmur, right? Carey-Coombs murmur. These are the named mid-diastolic. Of course, mitral stenosis, tricuspid stenosis are also mid-diam, but MDM, that is mid-diastolic murmurs only. Okay. So we are done with even third degree heart block. We are done with first degree AV nodal block as well. Now we are left with second degree AV nodal block. Okay. So we discussed regarding the now second degree AV nodal block. Second degree. What are the different types of second degree AV nodal block? We know we have Mobitz type 1, Mobitz type 2, and we have high degree AV nodal block. Okay. We have the Mobitz type 1. We have Mobitz type 1, and we have a Mobitz type 2, and we have high degree AV nodal block. We have the high degree AV nodal block. Remember, Mobitz type 2 with more than that of 2:1 conduction heart block is known as high degree AV nodal block. That means it is 3:1 or 4:1 conduction block is called as high degree AV nodal block. Up to 2:1 conduction, we call it as Mobitz type 2. Mobitz type 2 with beyond 2:1 conduction is called as high degree AV nodal block. That is Mobitz type 2 with 3:1 conduction block or 4:1 conduction block. Okay. Remember, out of which are the unstable rhythms? Mobitz type 2, high degree AV nodal block, and complete heart block. That is third degree. These are unstable rhythms. Remember, these are unstable rhythms. There is a high risk of asystole. There is high risk of asystole, and they are mostly due to structural heart disease. They are mostly due to structural heart disease. That's why they definitely require a permanent pacemaker. Okay, they usually require the permanent pacemaker. Whereas Mobitz type 1 and the first degree AV nodal block, they are usually stable rhythms. Okay, and they are usually due to functional cause, not due to structural cause, and function, and usually they do not require permanent pacemaker. They usually do not require permanent pacemaker. Okay, so where is the problem actually? Mobitz type 1 is also, that is second degree AV nodal block only. The problem is again at the level of AV node only. What is the problem? In first degree AV nodal block, it was delayed conduction. In third degree, it was complete block, right? There is no transmission of impulse from the atria to the ventricle. That is third degree. But in case of Mobitz type 1, it is also a pathology at AV node, that is delayed conduction like that of first degree, but with intermittent failure only, with intermittent failure of conduction, right? Because of this intermittent failure of conduction, that means all the impulses from the atria are not transmitted to the ventricles. So every P wave is not followed by the QRS complex. That means there is dropping of beats. These are the characteristics of second degree AV node block, dropping of beats. Because of the delayed AV conduction, what we get in ECG is prolonged PR interval. What we get is prolonged PR interval. Okay, this prolonged PR interval is actually one phenomenon, that is progressive prolongation is seen because of the fatigueness of the AV node. This is called as progressive prolongation of the PR interval. Progressive prolongation of PR interval. This is known as wenckebach phenomenon. Classically seen in Mobitz type 1. Okay, so how do you get the ECG? Like this, we have the P wave, PR interval, QRS complex. Again we get the P wave, QRS complex. Again we get the P wave, QRS complex, and we get the P wave. There is a dropped beat, P wave, QRS complex. So look here, there is dropped beat. That means the P wave is not followed by the QRS complex. And look here, the PR interval here is X. Here is 2X, here it is 3X. This is called as progressive prolongation of the PR interval. Shortcut to apply, just identify the dropped beat. This is drop beat, right? Look for the pre-PR interval as well as post-PR interval. Here, the pre-PR interval is 3X, the post-PR interval is only X. That means suggestive of progressive prolongation of the PR interval. This is known as wenckebach phenomenon. It's a shortcut to identify the progressive prolongation. Okay. Then what is the Mobitz type 2? The Mobitz type 2 is, where is the problem? It is not at the level of AV node. It is infranodal problem. Infranodal problem, right? If you know, this is a conduction system. It is not at the level of AV node. It is infranodal problem. That is his bundle Purkinje system. Okay, this is known as his bundle Purkinje system is actually involved in case of Mobitz type 2. Right, Mobitz type 2. Because in Mobitz type 2, right, it is here in Mobitz type 1, it is in AV nodal problem. Here it is infranodal problem. Infranodal problem. And what is that problem? Intermittent failure of conduction. Because of this intermittent failure of conduction, what we get is every P wave is again not followed by the QRS. Again, what we get is dropping of beats. But there will be PR interval will be normal. Why? It is infranodal problem, not a problem at the level of AV node. That's why the AV node is that is PR interval is normal. Okay. So how will be the ECG? This is a P wave. This is normal PR interval. Again we got to get P wave, normal PR interval, P wave, normal PR interval. Here we get the P wave, and again the dropped beat, P wave, normal PR interval. So here what we are seeing is dropped beat. That means dropping of beat. That is suggestive of second degree block. How to differentiate Mobitz type 1? Mobitz type 2, look for the pre-PR interval, post-PR interval. Here it is X, here it is also X. That means there is no progressive prolongation of the PR interval. This is suggestive of Mobitz type 2 heart block. Okay, that's it. We are done with the different types of heart block. How do you approach a ECG examples as well? Okay, here look at the heart rate first. How do you calculate the heart rate? It is 300 divided by number of large boxes between the RR interval. This is one R way, this is another R way. This is in between them, we have RR interval. Calculate the number of large boxes between them. 1, 2, 3, 4, 5, 6. Therefore, 300 divided by 6, that means 50 beats per minute. Therefore, it is a case of bradycardia. I told what? Bradycardia. The first step you have to plot is AV dissociation. Look here. This is a P wave followed by QRS, P wave followed by QRS, P wave followed by QRS. That means there is a relation between the P and the QRS. That means AV dissociation is ruled out. After ruling out AV dissociation, what is the next step you look for? Is dropping of beats. Look here, every P wave is followed by the QRS complex. That means there is no dropping of beats. That means second degree heart block is ruled out. So then we are left with sinus bradycardia and first degree. How to differentiate between them? Look for the PR interval. Okay, look here, PR interval from start to start, right? 1, 2, 3, 4, 5. That means 5 small boxes. No? 5 small boxes means normal. That is 0.2 seconds. Therefore, it is a normal PR interval. Therefore, it is a case of sinus bradycardia. Come to the ECG 2. Look here. What is the heart rate here? Right? In between them, na? 1, 2, 3, 4, 5. Almost 5.5. That is 6. We calculate. 300 divided by 6. That means 50 beats per minute. That means this is a case of bradycardia only. So, is there any AV dissociation? No. So, third degree block is ruled out. Is there any dropping of beats? Look here. Every P wave is followed by QRS. P wave followed by QRS. P wave followed by QRS. This is a P wave, QRS. P wave, QRS. So, there is no dropping of beat. That means second degree AV nodal block is also ruled out. What we are left is first degree versus sinus bradycardia. How to differentiate between them? We have to look for the PR interval, right? Look here. Almost 1.5. That is 1.5 large boxes. One large box is 0.2 seconds. That means it is more than 0.2 seconds. That means prolonged PR interval. That means it is a case of first degree AV nodal block. First degree AV nodal block. Okay. Come to the ECG 3. Right. Here look. What you are seeing is dropped beat. There is a P wave, right? But that is not followed by the QRS complex. Look here. There is a P wave followed by QRS. There is a P wave followed by QRS. P wave followed by QRS. Right, look here. The P wave is not followed by QRS. That means there is a dropping of beat. Whenever there is a dropping of beat, we straightforward make a diagnosis of second degree AV nodal block. AV nodal block. Okay. Then how to differentiate between the Mobitz type 1, Mobitz type 2? I told what? Look for the, identify the drop beat. Look for the pre-PR interval, post-PR interval. This is a dropped beat, right? Here we have the pre-PR interval. This is post-PR interval, right? This is pre-PR interval. Look, there is a the pre-PR interval is somewhat more when compared to post-PR interval. That means progressive prolongation of PR interval. Therefore, it is a case of Mobitz type 1 heart block. Okay, come to ECG4. Again, you identify the dropped beat here, right? You identify the drop beat here, right? That is not followed by QRS. That is dropped beat, na? Right? Again here dropped beat. I told what? Look for that. These are 2 hours dropped beat. Pre-PR interval versus post-PR interval. This is pre-PR interval. This is post-PR interval. Almost both are similar. That means there is no progressive prolongation of PR interval. Therefore, it is a case of Mobitz type 2 heart block.